We've got 47 in here. I'm going to get started and continue to let people in as they come. For those that are in here, thank you very much for joining us. My name's Emily, part of the Montana Public Health Training Center, here with my co-lead Alexis Wolf. We have a very cool seminar for you this morning with Cora Newman and friends. She will describe the other wonderful guests we have with us today. And basically, you don't need to have your video on for this if you don't need. And we're going to be using the chat box for questions. So please keep that open for specific questions to the hosts and to our presenters so that there's so many of you so that we don't want to miss any questions throughout. That's all I have for now. I'm going to turn it over to Cora. Again, me and Alexis are here though, so feel free to even private message us if you have any questions.
Thank you so much, Emily. Thank you, and welcome everyone. I believe we also have Dr. Greg Holzman on, our state medical director. So I'll be making intros shortly. Just want to make sure everybody's on. Good morning. My name is Cora Newman. I have a background in public health. Some of you may know my name. I ran for U.S. Senate here in Montana and have a background, grew up and am based in Bozeman. And have a background in public health, have worked with Indigenous, Native, and rural communities focused on access to public health and social services across the world and across the U.S. I was part of the Ebola response in Africa and have recently, since we've been faced with COVID here in the U.S., have been working with this incredible team, the COVID local team, and leaders across the state on COVID response. It's my pleasure to introduce our speakers today. We have a lot of public health experts from across Montana on this call. So we don't, this call is, we've hosted a few town halls, public health town halls with the public to answer questions about COVID in Montana. This training is really focused on a set of really comprehensive tools that this group has developed. And so we're gonna be running through the tools. We want to really get some more resources into all of your hands. I see that we have public health officials from multiple counties. And so our goal here today is we wish that we didn't still need these tools, but we do. We're facing a continued increase across the US and across Montana. And so we wanted to make sure to get you some resources that you could use in your response within your communities. So really happy to have you here today. We'll go through the COVID local tools. Hear directly from the experts. We do have Dr. Holzman and Dr. Cook-Shimanek to talk about what's happening currently here in Montana, and then we'll open it up for Q&A. But thank you very much for joining us today. I'm going to just run through our bios and then pass it over to Dr. Beth Cameron. So Dr. Cameron is the Vice President of Global Biological Policy and Programs at the Nuclear Threat Initiative. You may have seen me posting and talking about her and her colleagues leading COVID local. She actually served at the White House running what we refer to as the White House pandemic team under both Obama and Trump. And that was the White House National Security in the White House National Security Council. There she was instrumental in developing and launching the Global Health Security Agenda, this pandemic playbook, and addressed homeland and national security threats surrounding biosecurity and biosafety. So we're really honored to have her with us today. She's doing incredible work across the state and across the country. We also have Jessica Bell, who's a Senior Program Officer with NTI, with the Nuclear Threat Initiative. Her primary role is leading COVID local work, as well as NTI's Global Health Security. And if you all can just kind of wave, I know we have the screen share up, so we may not be able to see all of you. But yeah, if you can just say hello when I say your name, Jessica. We also have from the COVID local team, Haley Severance. She's a Senior Program Officer with NTI. Her primary role is leading NTI's Global Biosecurity Dialogue. Haley previously served as a Senior Policy Advisor in the Office of the Deputy Assistant Secretary of Defense for countering weapons of mass destruction. We have Jordan Schermerhorn. She's a Senior Research Associate at the Center for Global Health Science at Georgetown University. Her research interests center on infectious disease detection and response in conflict settings, fragile states, and extremely low resource areas, with a geographic emphasis on Sahel and the Horn of Africa. And she's working with Rebecca Katz, also at Georgetown, who's part of the leadership for COVID Local. And then finally, we're really honored to have some of our top Montana public health experts on, Dr. Greg Holzman, who's a state medical officer for Montana DPHHS. Prior to joining DPHHS, Dr. Holzman served as director of Healthy Campus Initiative at Michigan State University, as deputy director of the Office of State, Tribal, Local, and Territorial Support at the Centers for Disease Control, CDC, and chief medical executive for Michigan Department of Community Health. And finally, Dr. Maggie Cook-Shamanik. She is the medical director for the Montana Department of Labor and Industry, and works as a physician with the Montana Department of Public Health and Human Services. So a really incredible group of experts here today to talk us through the current status here in Montana and the tools that we can use to address COVID across our state. So welcome, everyone. I'm going to pass it over to Beth now. Dr. Cameron.
Thanks so much, Cora. Thanks, Emily. Thanks to the whole team and to especially all of you who are participating today. And thanks very much to the organizations that are part of COVID Local, which is the Nuclear Threat Initiative, where I'm the Vice President for Global Biological Policy and Programs, as well as the Georgetown Center for Global Health Science and Security and the Center for Global Development. So this has been a collaborative effort which was put together in order to assist decision makers in order to make early and continuing decisions during COVID-19. And you'll be hearing more about COVID Local from my colleague Jessica Bell in just a minute. What I wanted to do is just really quickly frame where we are in the outbreak nationally, but also comparing us a little bit to what's happening with the rest of the world. And I do that for two reasons. One, to highlight a couple of the key challenges that we're having here, but also to provide some hope that we can do this. We can suppress this virus. It's possible to do. It's been very challenging and we've had a hard time with a unified response across the country, but I believe that we absolutely can do it. There are many things that we need to do in order to get to that place, but I have hope. So I'm gonna quickly share my screen and just show a couple of really, really quick slides so that we can get into the meat of what we want to talk about today. So today in the United States, we are at now, this is from 2 evenings ago that I made the slide, we're now at over 4 million cases of COVID-19 in the United States and almost 150,000 deaths, with about 1,000 deaths per day happening at different points along the last 7 days. So we're not in a very good position, and this shows the world, and I do this for two reasons. One, to show that we're not the only country with some challenges right now, although we are by far the country that is actually driving the pandemic now around the world, which also makes it an imperative for us to control the disease, not only for ourselves, but for everyone else. But if you look at the bottom and you look at countries like United Kingdom, France, Canada, all of which had challenges early on, they are now doing a much, much better job. And so it is definitely possible as we look at the EU, which has collaboratively been able to control this epidemic and has about the same number of, slightly more people combined than the United States does. We can absolutely do this across our states. Some of the key, whoops, I'm having trouble getting, there we go, thank you. Some of the key things that are facing us right now, one, testing turnaround time. I think this is a problem everywhere in the country, including in Montana. And we know that the two major commercial labs for the country for processing tests, Quest and LabCorp, are both sending up warnings to the country saying that they're not going to be able to process tests quickly, especially in cases where you're not a healthcare worker or not in the hospital. That's going to compound when we get into flu season. And so finding ways to better share capability across states, and also to be able to even make more tests and make more reagents. Those are things that our country is absolutely going to need to focus on, and urgently. On the top of the slide on the right, you can see what Quest has been saying this week, and on the bottom you can see what's happening in Europe, which is that 95% or more of people who are going through the national health system are able to receive tests in 24 hours. And that's because there's a much, much less load of the virus. So once we get into a position where we've controlled our caseload, we'll have a much better time conserving tests and getting a quick turnaround. But right now we have such a high caseload that that's been very challenging. On the left, I just wanted to highlight that this is a disease that, and you'll hear more, I'm sure, throughout the course of today, that is impacting our country in different ways. And in particular, impacting racial and ethnic minorities, and including by age range. So this slide highlights associated hospitalizations with COVID-19 by race, ethnicity, and age. And in particular, you can really see the percentages, the shocking percentages of hospitalization by age in the Hispanic and Latino population, the American Indian and Alaskan Native population, Asian and Pacific Islanders, and obviously Black Americans. Second, sorry, there we go. Last slide, apologies. I'll just show it this way to, let me get it back on the screen, is just to show you test positivity rate. So this is a good news slide for Montana, which is, and you know this already, Montana's done a good job relative to the rest of the country in being able to control cases. Obviously there have been challenges in different environments, particularly in tribal communities, but we're looking at percent positivity rate for tests. So that's the number of positive cases over the total number of tests that are done in a given day. And what you want that number to be is below 3%. And this shows states that are green if they're below 5%. And so I show this because the countries that are in red, and to some extent, or orange, the countries that are in sort of that yellowy color, those are really driving the test demand across the country and making it really challenging for the countries that are, states, for the states that are in green to be able to control the disease. And so this is where you can really see that we are one country and we're having a testing crisis across the country that's affecting us all, but it's being driven by the high caseloads in the states that are in red and orange here on the slide. And so that makes it even more imperative to be working collaboratively across counties and across state lines with partner states in the region and around the country. So I'll stop there. I won't offer specific solutions, but I am happy to take questions when we get to that point. Thanks.
Thank you, Beth. Yeah, and I think you know, things are changing so quickly, and week to week it feels like, it can feel like it's a completely different scenario across the country. So it's really great to get that overview and to have your perspective on you know, that we can get this under control, and if we work together and coordinate across states, that there's a lot that we can do to continue to, or to get back to where we're flattening the curve.
Yeah, and I think it goes without saying, and you'll see this in looking through the COVID local tools, but maybe it is important to explicitly state that one of the things that the country is really lacking is a common set of metrics that are reported by all states regularly for things like test positivity rate, for decisions about when to do a stay-at-home order and at what point, what incidence level of COVID-19 would drive that. And that's completely different across the country right now. And that's something that states really need to, in my opinion, agree upon so that we can look at, as a country, at where the outbreak is and what policies could be put in place to help suppress it, to include mask wearing and to include making sure that we have faster turnaround times for tests, to include many of the other things that we're going to be speaking about throughout the course of the day. I'll stop there.
Thank you so much. Pass it over to Jessica, who's going to give us a little bit more detail about the COVID local tool and the run of show today for our presentation.
Great, thanks Cora, thanks Beth. So as Beth mentioned, our COVID local team is comprised of NTI Bio, Georgetown University Center for Global Health Science and Security, and the Center for Global Development, as well as Thales Analytics. We moved out on this project in the March timeframe with the intent of providing local leaders a detailed guide to navigate an effective COVID-19 response in their communities. And we wanted to create a site that provided tools and resources and a platform for feedback and support to local leaders. So we created COVID Local's Frontline Guide for local decision makers. This guide outlines a number of key objectives, priority actions, indicators for assessing progress for a local leader, as well as metrics that Beth just spoke to. And this site includes a unified set of metrics. So it allows the community to have a shared vocabulary as well as a shared way of presenting the data across jurisdictions. Our guide was developed by an experienced group of practitioners and academics, so across private sector, academia, as well as former government officials. We're now 4 months into refining the content and providing additional tools to help with local decision makers. And today's presentation, we're going to walk through those various components of an effective COVID-19 response and also hear from experts such as Dr. Greg Holzman, Dr. Maggie Cook-Shamanik on even the specific Montana data sets. And so I've placed in the chat a link to our COVID local website, covid-local.org, which we'll be referencing throughout today's discussion. But I did want to quickly share my screen and just walk you through some of the components of the website. So here we go. Can you all see my screen? All
Yeah.
right. So this is the COVID local landing page. And so when you get here, there's a series of options. You can drill down into the metrics for a phased reopening, also found in the top guide. Top ribbon. Next to that, we have the guide. So we have developed a US-based guide as well as a low and middle income country. So a more internationally applicable guide for local leaders. Next, we have a series of resources and blogs about, if you're interested in seeing who the contributing authors are to our project. And then later, my colleague Jordan will walk through COVID AMP, which is the analysis and mapping of policies database and model that we just recently launched, and we're very excited. So it's great that she's going to walk you through that. And when you choose some of these options, this is what pops up. You see a very detailed list of priority actions, which we'll hit on today, but also questions. So it's an interactive, downloadable guide that you can walk through not only what are the questions I as a local leader or public health expert need to be asking of my community, but also what are those metrics? What do they look like? What should I be focusing on that gets me from phase 2 to 3 to 4 and into a safer environment? We also provide checklists for these metrics. So an interactive way to walk through the material and quickly understand how to progress to a safer environment. Also downloadable. So that is the website in a nutshell. We're gonna, throughout this presentation, go back and forth to drill down into some more of the components of it. But with that, I will pass it back to Cora, who's going to give just a quick snapshot of where we are right now with Montana numbers. And then Jordan and Greg are going to dive down into more of what that data and metrics look like.
Thank you. I have to remember to keep unmuting myself. Thank you for that. And so, yeah, that gives it, there's a lot on that site, and I definitely recommend all of you to spend some more time going through the site and really looking at the tools, because there's not only how to gauge your progress, but and we'll go through them, a number of tools to see where we are and guides to use with your community and outreach. So I'm sure all of you check this every morning, but I just wanted to give a quick snapshot of where we are in Montana today. We have as of yesterday and this morning, it will be updated soon, 97 new cases. And this bottom here is the cumulative cases that we've had, COVID cases that we've had since the beginning, or I guess early March. We do currently have an outbreak in Yellowstone County. The rates have continued to be some of the highest in Gallatin County, and they're growing across the state. We have seen, and we'll talk about this a little bit more, some incredible leadership by our local leaders. Not only our governor he shut down earlier than most states, especially in our region. And we had a really strong trajectory with flattening the curve early on. Montanans really followed the guidelines, stayed at home, and we kept the curve. We flattened the curve and really protected our frontline health workers and our communities. And we got to a place where it looked like we were ready to go. And we'll talk more about this phased reopening approach. But we got to a place where we were ready to start to loosen and open up. And that is where we're seeing why we're seeing some of the spikes that are coming through now. So I'm really happy to have Dr. Holzman on today with us, who can speak more in depth. But this is a place on the Montana coronavirus website where we're all tracking the cases as they rise, and I was personally, and I know that most of us on most public health officials and practitioners were very happy to see the mask mandate, which came through last week, which is definitely we're hoping and expecting to see an impact from that. But one of the biggest challenges we have in Montana is this two things: the perception that because we have so much space, open space and beautiful clean air, that that we are somewhat more protected, right? And there is the open, the being outside and distance from each other does help, but this is an incredibly contagious disease, and so that space can be misleading. And then we also have tourism. We have 12 million tourists coming through our state every year, and currently it's incredibly difficult to track and trace tourists coming through the state. So there are a couple of different reasons that we're seeing these spikes, but really glad to see that mask mandate being put in place and hoping to see a slowing of the spread in the next couple of weeks here. But Greg, I'm going to pass it over to you if you're on, and we can just go to the next slide, and would love to hear a snapshot from you on where things are right now with COVID response in Montana.
Sure. Thank you, everyone. I really appreciate it. I was just, before I start, I was going to add on a few things to Dr. Cameron's comments. And, I'm an academic. My career has been either in academia or public health. I kind of switch back and forth a lot. And epi and data is, I believe, wholeheartedly in. And I completely agree with Dr. Cameron's concepts about uniformity and information would be very helpful across the board. But to add to that, I'd also say, and I think it's a major challenge that we have here in the United States, is we also need a collective response by individuals. And there's so much responsibility that needs to fall on us. And I think the data that we show comparing ourselves to other countries really shows what we can do. There's no reason we can't. But it does take a community response. It does mean a lot more than each individual trying to just do one thing. And that's what public health has been about since its inception and has made some huge strides. And we're putting ourselves through the test right now. And right now we're not doing very well. So just wanted to bring those points up together. As far as Montana is concerned, a couple things with the data. Again, one thing I found in this is that we have a lot more people that are epidemiologists in the world than I thought at the beginning. But comparing the data and making sure that you're comparing apples to apples and oranges to oranges, there's some things to look at. And of course, when this first came out, we heard over and over again about the flu and flu data, and we still get these numbers connected to each other. The flu data that we have from the CDC, one is many, many years of experience. This were in 5 months of it, 6 months of it. But also the numbers we have here are actual death certificates reading with coronavirus. And there's probably a lot more out there than we actually are reporting at this point in time. We'll get more of that as we go on. The flu deaths are done by a sampling and then trying to make a decision of how many flu related effects have happened. So that's another thing to look at as we kind of track these things. But it is still, and I've said this over and over again about epidemiology. Epidemiology is like cutting with a butter knife. It's not a clean cut. All our data has faults and problems, but the more you can put it on top of each other and on top of each other and look at it from different angles, you get a clearer and clearer picture of what's really going on. And so we've been working really closely on pulling together our partners, working very closely with our local public health, who, as many of you know, in Montana, we are a home rule state. So the individual counties can do anything more, and the health officers have the authority to do more than what we're doing at the state level. They can't do less as far as the orders and guidance that are coming on. That helps a lot in the aspect of we're a huge state. 6 states on the East Coast could fall into our state. So what's happening in Kalispell might not be what's happening in Billings, and definitely what's happening in Billings might not be what's happening in Plentywood or something of that sort. So being able to adapt and work together is the best way we can really kind of address this situation. But again, more uniformity across everything. The governor does have, you know, the 4 people or more, it becomes a mandate to wear a mask. Although we all encourage everybody, no matter whether you have no cases in your county or not, to be wearing that mask, because oftentimes when we find the cases, it's already piling along. We do track a lot of different things here at the state data-wise. Of course, we have the exact numbers as best we can, I should say, from positive COVID cases coming in. We also have the number of cases that we're seeing from death certificates and aspects of that. The hospitals are constantly reporting how many beds they have, that they have a COVID patient in a bed, how many are on a ventilator, how many patients are in a COVID room to be ruled out for COVID, meaning that they're sick enough that they have to be in the hospital. We also keep track of how many ventilators are in the area, all those kind of aspects, and keeping track of the positivity rate that Dr. Cameron talked about. That she picked a good slide because we've actually gotten a little worse. I think we're about 6% positivity now, but it is an area that is really important to look at and shows that we're testing, one, we're testing enough, and 2, that we're keeping the virus suppressed. So that's another data set. The other thing we have is we have what we call syndromic surveillance, and this came about after 9/11 actually, and the anthrax cases, but many of the states do this. We have, I think, about 85% of our ERs are reporting, and they put in, we get de-identified information coming from the labs on kind of the chief complaints that people come into the ER on. And just to give you an example, during the fire seasons, I can tell that we see many more respiratory people coming to the hospital with respiratory complaints during that time, and what regions. And it's broken up into all different aspects, whether it be GI or something of that sort. This way we can have an early surveillance if something is going on. We are also following that for what we call ILI, influenza-like illness, and also looking at those things for some people that are coming in with respiratory types of things, and looking at that, and also with COVID. We also have that a surveillance program that we do have out there working with Sentinel providers that we have been doing for a long time, looking at the number of patients coming in with ILI, influenza-like symptoms. So all these we can kind of map on it. If you look on our website, and I can pass that on to pass out to the group if people don't have it, but every 2 weeks we put in an in-depth epidemiological kind of point to look in more detail at what's going on. So it will have all this kind of information. It shows the graphs of how we're doing over time, very much similar to the COVID view that the CDC puts out, but at a much smaller level and at the state level. So it kind of allows us to see what's going on, and also by county. So I do recommend people taking a little look at that. And I hope that answers the questions that you wanted me to do on this slide.
That's
But if
great.
there's other things you want me to specifically say, please let me know.
We're just really glad to have you with us and to give some more in-depth. I know there are a lot of questions just because there's so much to track with COVID. And I think that that's one of the things that we've seen evolve over, it's just been a few months, although it feels like a year or more, but, understanding where we are, what's the phase, and what are the behaviors? Is it masking or distancing, or, so the communication side of this is so incredible. It's always important in a pandemic. It's critical, but it's even more important with COVID, especially when you're getting so many mixed messages from so many different leaders. And so it's really great to have you on to answer some of those questions. And we'll keep going through the tool, but if you're able to stay with us, it'd be great to have you for the Q&A as well. So yeah, thank you, Greg.
I'd be happy to stay on. And I would just add, I do think we need to make the messaging as simple as possible. You might want to go in more depth in different things, but it is as simple as the 3 W's, wear a mask, watch your distance, wash your hands if you're a business or anything, cleaning off highly touched surfaces, staying home when you're sick. it's not rocket science. There's nothing really magical. It's just something that we need to get to be our normal behavior right now. And I think we would see some significant changes happening. And
Yeah.
those.
You joked at the beginning about everybody being an epidemiologist at the beginning of this outbreak, but one of the things I actually wrote about in the very beginning was that we're all public health leaders now. Like every single person is a public health practitioner, because you know it's right down to the household level on every one of us to follow those really basic guidelines. That's the baseline, and so we're all responsible for how this goes. So I just want to hand it over to Jordan now from Georgetown to talk a little bit. We're going to keep going through this tool, so we want you all to know how to use it, to talk a little bit more about understanding the current data and metrics, which Beth did introduce some at the beginning, and we will continue to get into it as we go through this presentation. But Jordan?
Sure, yeah. So to link all of the Montana-specific metrics Greg discussed to the tools that COVID Local has developed, I'll dig a little bit more into this slide. So the COVID Local team has developed several sets of metrics that cover different elements and dimensions of the COVID-19 response, with the goal of providing a framework for thinking about reopening decisions and re-restricting decisions as well. I think one clear challenge we've encountered with COVID is the lack of information in some places, but also a very pressing need to make decisions with the information we have. So this funnel graphic right here is broken down into much more detail on our website, but I'll run through the broader framework really quickly. So we consider 4 different stages, progressing all the way from the severe lockdown that many places experienced in March and April down at the bottom. And that would be where the strictest distancing measures are in place, all the way up through initial reopening efforts to an adaptive new normal. So we've linked each of these stages to a set of recommendations for activities and tasks that we think need to be completed before moving to the next stage. For example, in one of the call outs here, you can see that before implementing broader reopening measures, you would need to have established a protocol for managing access to tests, especially if testing capacity is limited. For example, do you limit tests to specific populations, et cetera? So how do you know where you stand? We've provided specific recommended metrics for transitioning between these phases. Again, that might mean moving up the funnel to fewer restrictions, as well as moving down the funnel to reimposing closures and other control measures. As Beth discussed at the beginning, one of these involves test positivity rates. So I think it's probably a little bit small on this slide, but from moving from lockdown into initial reopening, we've recommended that fewer than 10% of tests are positive in a given locality. To move up to broader openings, perhaps permitting small indoor activities, just as an example, we've recommended fewer than 3%, and then moving into new normal, fewer than 1% of tests being positive on a daily basis. Test positivity rate is—
Do you mind if I just zoom in on this, share my screen and zoom in on this image a little bit? You can keep talking.
Yeah, that would be great. I'll wait for you to do that before I move forward. There we go. So test positivity rate is obviously not the only information you're receiving. So Cora, if you could click through a little bit up at the top, we've got diagnostic, testing, and surveillance. So we've provided similar guidelines. For example, delays in test results. Are the majority of people receiving their test results within 48 hours, within 24 hours? And people need that for their individual decision-making, as well as collective decision-making about how much infection might be occurring before people know that they're infected. I'm speaking to you all from Texas, where it takes anywhere from 1 to 2 weeks to receive test results. So you all, I think, are in a better place than we are at the moment. And then we provide similar metrics for contact tracing. For example, what percentage of contacts of known cases are reached within 24 or 48 hours, and how many contact tracers do you have, and is that a number sufficient to contact folks who might have been exposed and to tell them to self-isolate? You can see up at the top, we've also got healthcare readiness. what percentage of ICU capacity is available, and what percentage of ICU capacity is taken up by COVID-19 patients. You may move through those different stages differently at different types of the year. For example, flu season, those metrics might change and alter your decision making. And then finally, whether sufficient support is available for high-risk populations. For example, is sufficient personal protective equipment available in long-term care facilities? So not every locality will be in the same phase for every dimension of this response. For example, maybe in a rural area, your test positivity rate might be low, but your ICU capacity might be high if you've got a smaller ICU. So that might alter your decision making. But the goal of this COVID local tool is to provide a framework for considering these metrics holistically and considering where you are in all dimensions of response before making these decisions. So as Jess mentioned, to begin with, on the COVID local site, there's an interactive scorecard where you can assess your progress and see which of these recommended stages your locality might fall under based upon the information you have. And that's all I've got for metrics. I think we'll move on. Yeah, thank you.
Thank you, Jordan. Yeah, so and we are officially in Montana, correct me if I'm wrong, Greg, but still in phase 2 and have not been able to move out of that. But these tools work not just for statewide, but also localities and counties, right? So it's nice to see that all the public health officials that are on this call can be using these tools locally as well. And I think it's great that there's, they have access to tools that they can use at every level. Great. Next, we're going to talk about taking action to delay and reduce transmission. Maggie, are you, Dr. Krukshemenek, are you on?
Yes, I am.
Okay, great. It's great to have you with us. So would love to, the next phase to think about and to focus on is obviously the immediate and then ongoing is taking action to delay and reduce transmission. I feel like this is something that we talked about, the importance of having the messaging be very clear on this, but it is something that people continue to need to be reminded of. Even with the mask directive that we have, it's masks inside businesses in counties with 4 or more cases. That changes. So the mask behaviors around actions to delay transmission actually change over time and depending on locality. So it's really important to continue to really go through and consistently communicate what is needed. But it would be great, Maggie, to have you speak a little bit more about where we are in Montana with outlining those guidelines. And I know that you're also responsible for looking for managing surge capacity and making sure that facilities are equipped. Oh, I'm sorry. Actually, it's Haley who's on this slide. My apologies, Maggie, you're on the next. So yeah, great to have Haley, if you could speak to the actions that are required that I think, again, we've been hearing a lot about them, but it'd be great to go through them in more detail.
Sure, and yeah, I would welcome definitely comments from Maggie or others from Montana on the specifics within your state, but I'll just be going over kind of the general support this tool provides in this area, which is a very important factor of COVID-19 response, which is slowing and reducing transmission. And we'll also be covering quickly protecting vulnerable populations, which is also a key factor. And just how these COVID local tools might help you both set up the appropriate preparedness systems, as well as help you evaluate your level of preparedness and the progress toward effective control of the outbreak. So first, I would like to turn attention toward the slow and reducing transmission in communities. When you look at the domestic guide, this is actually key objective number 3. And what this section provides is a focus on priority actions, which you see are up on the screen here, that local decision makers can take to reduce disease transmission in the community. For example, implementing those social distancing measures such as shelter in place or stay-at-home orders, which we know are never super popular because of their highly disruptive nature. However, these measures are put in place really to reduce the burden on the healthcare system and to ultimately reduce severe outcomes and fatalities as a result of infection. And we'll hear more about the healthcare burden in the next section. Of course, local governments should follow state and national guidance in implementing social distancing measures, but they also have to take into account local risk factors. So, and just in general, distancing practices during the early phases of an outbreak, as you likely saw in the beginning of COVID-19, should be calibrated to be a little bit more aggressive than observable local conditions might intuitively suggest. But that's really to try to, as we say, flatten that curve early on. So I won't go through in detail some of the priority actions. You'll see them here and you can see them in the guide. But they really provide broad actions that leaders could take. But the tool, when you dive into it, it does provide more in-depth operational requirements checklist associated with these priority actions. And it gives resources to help you actually implement those actions. An example might be something that the whole country is now discussing and struggling with, which is school opening. So it would have been great to, you know, if all of local communities had in place a couple months ago clear criteria for when to recommend canceling schools, for how long, maintaining clear and open lines of communication with district leadership, you know, developing remote teaching methods in case they're needed. So these operational requirements really set up the systems that you might need in place to prepare for either a future outbreak or a change in the direction of transmission rates. So once transmission rates within the community have decreased and the burden on the healthcare system has stabilized or declined, it will become possible to consider incrementally relaxing the range of social distancing measures. This is when you can assess how effective your efforts have been using those metrics that Jordan just reviewed. The lifting of social distancing measures, or what people have been referring to as the reopening of communities, should be done in a phased manner that we've outlined in that funnel, and should be dictated by those metrics. And just to know, it's not only a forward motion, but as we've seen in other parts of the country, for example, my family's from New Jersey, and you know, they were gonna go to phase 3, but then the governor said, nope, you know, we have to stay in phase 2, you know, due to the metrics that we're seeing come out. So it's not only forward progress, but you may have to go backward to earlier phases if the metrics indicate an increase in transmission. So that's all I'll cover in that section, but I want to quickly cover also the at-risk or vulnerable populations, which is key objective number 4 in the guide. So as we know, COVID-19 poses risks to older populations and those with complicating health conditions, and we're learning more and more about additional vulnerable populations as we go. Each local context is unique, and each local emergency management system should really take into account a very specific list of vulnerable populations in the sites in which they congregate or live. And I'll turn it over shortly to Cora, who can really discuss this topic in the context of Montana. Again, the key actions are listed here, and the guide does provide more granular actions that you can actually take as you look at that resource. I do want to point out that since the needs of different populations vary quite significantly, our resources list for this section of the guide is quite long. You'll see if you look at it, we have community solutions for homeless populations, for migrants, for individuals with HIV, and others based on the specific needs of those communities. So it's a really good collection of resources.
Kelly, do you mind if I share that real quick? I'm just going to do it again so that people can see it up close a little bit more. But I don't want to interrupt you.
So my final point on this is just to mention that COVID local metrics for phased reopening, as well as the COVID local indicators of progress related to preparedness, both include considerations related to vulnerable populations, which Jordan showed you a preview of. So you can measure both your level of preparedness to protect these populations, as well as your level of success in actually keeping these populations safe. So that was all I really wanted to cover in this section, but Cora, I know you wanted to discuss a little bit about vulnerable populations in Montana.
Great, okay. So you can, yeah, stop sharing and we can go back. Yeah, so those tools are, again, really helpful to go through point by point. And what we're seeing here in Montana, and it's been great to see our state task force and our public health team really prioritize vulnerable populations, aging populations. Montana is an aging state. We have a high proportion of elderly here, and also our Native communities. Our Native communities are sovereign nations with their own public health infrastructure and systems, and they've done an incredible job. They actually shut down just as quickly as the governor, and there's been a really concerted effort to make sure that we're getting out and regularly testing and providing PPE and resources to those communities. The challenge is that when COVID arrives in facilities like nursing homes, prisons, and in high areas with high rates and high proportion of vulnerable populations, and across our Native communities, you see a much higher rate of transmission. So we have seen some really good, strong efforts. One of the things, a couple of the issues that have been coming up recently, as we've seen, especially in Yellowstone County, we now have 20 deaths that's related to nursing home, but there is an ongoing spread on Crow Nation. We're seeing cases on Salish, Blackfeet, Rocky Boy, and they're taking really swift action to try their best to isolate and do contact tracing. But one of the biggest challenges that we have heard about, and this dovetails into the next slide, and into the next topic, is facilities and capacity to help individuals quarantine. A lot of communities, especially in our Native communities, have multiple generations living in one household, and multiple people living in one household. And so one of the biggest, we actually convened this same task force, the COVID local team with tribal leaders last week. One of the main topics that came up was how do we isolate those who contract COVID. And there's been a lot of conversations about purchasing mobile homes and finding overflow facilities and facilities where we can house these people, because the first line of defense is the 3 Ws, as Greg mentioned. But then once people contract COVID, where are they going to be safe and isolated? And so I would love to have Maggie speak a little bit more to our surge capacity and where we are. Maybe a few snapshots from across the state in terms of helping to slow the spread at that next line of defense.
Sure, thank you. So I just wanted to talk kind of briefly about what goes into surge planning for different hospitals. And so this is something that is not unique to COVID. Hospitals are routinely creating surge plans and also exercising those plans in tabletop exercises and that sort of thing to prepare for events like COVID, which happens to be an infectious disease, but in other emergency scenarios, surge planning might be necessary as well. And so just fundamentally with surge planning, hospitals are looking at essentially 3 different areas. And so they think about space, which we just talked about with kind of space for quarantine and that sort of thing, but space within their facility, and they're looking at staffing and ability to respond to a certain situation in terms of medical and support staff. And then also supplies. And so you see that mentioned on here, in PPE, personal protective equipment, has been one of the areas that's a hotter topic with COVID, simply because there are precautions that need to be taken, particularly in a healthcare setting. And so when we talk about those 3 areas, so space, staff, and supplies, we think about them in terms of kind of what is conventionally available. So for medical care, for example, what do we need in those 3 areas to have normal operations? So once things become stressed in any of those three areas, you're really moving along a continuum from that conventional capacity to contingency capacity. So what sort of modifications do we need to make in any of those three areas in order to continue or to be at normal operations, or kind of get as close as you can to normal operations? So those things can move fluidly back and forth. For example, if PPE, personal protective equipment, is short on supply, they might move into a contingency sort of strategy to deal with that. But they can very easily, once they're replenishing their supplies, move back into their conventional status. So further along that continuum, so you're going from conventional to kind of contingency plans, and then you get into sometimes crisis situations where essentially, you know, you're dealing with short supplies, short staff, short space, and you're needing to make changes to the way things are operating in order to get away from that crisis situation and move back towards contingency. So it's really a continuum, it's dynamic, and people and institutions are moving across that on a regular basis when the system is stressed. And so a lot of times hospitals will establish kind of triggers or decision points where they're going to move from one to the other area. So along that same lines, when we're talking about space, we often think of alternate care facilities. And so when hospitals no longer have space, for example, to care for patients, they may need to seek other sites. And that's where alternate care facilities can come into play, where they're almost like a field hospital type situation. And currently the state has been working with Kalispell Regional Medical Center and also Bozeman Health to explore options with respect to alternate care facilities. And so that's kind of a general overview. I'm not sure if people have questions, but I'd be happy to answer.
Yeah, thank you so much, Maggie. I think there will be questions, and I have a few of my own, but I think we can keep going. And if you're able to stay with us through Q&A, that would be great as well. I think from what I can tell, and it would be great to have you chime in, and if anyone else wants to, but just right now is that it does look as if we are at this point still okay with our ICU bed capacity in terms of treating patients. I think one of the things that seems to be a bigger challenge that I'm hearing about more regularly is where to isolate people in those multi-generational households. But it is good to know. And am I right with that, Maggie, that it looks that at this point, from what we can see on the data that's available, that we're still okay in Montana with beds that are available?
Yes, that would be my assessment. I'd ask if Dr. Holtzman has anything to add to that.
Getting to unmute, sorry. No, I agree with what Maggie said. At this point in time, we're doing all right, but we have seen the number of hospitalizations increase in certain areas around the state. So it's something that we take very seriously, and we're watching very closely and hoping to get in the mitigations that we don't get into a place of crisis. But at this point in time, we have enough beds, and
we want to keep it that way. Yeah, keep slowing the spread so that we can keep that. Let's keep it that way. Thank you both so much. So the next slide actually is going to be a little bit more. The next section will be a little more interactive. One of the things that, public health, as you all know, all those of you that work in public health, are can operate best if you're able to get real-time and regular feedback from the communities that you're serving. So we actually, I think that some of you may have questions right now for each other, but questions that you're struggling to get regular feedback from your communities around. So we have a quick poll for you all. It's just, Emily just put it up, which is focused on performing regular risk assessments, and so that leaders can, in order for you to continually get timely, regular feedback to your communities, you need to be hearing from them. And I know one of the things Dr. Holtzman brought up yesterday in our conversation was looking for more regular feedback, or just understanding from you all feedback that you're getting in terms of quarantining. Are people quarantining? And I'll let you, Dr. Holtzman, you can ask that additional question as well. But timely and regular open communication is really at the heart of a public health response. So the questions are via public forum. So how are you communicating and engaging with local leaders? So you're obviously some of you are local leaders, but how are you communicating across with one another? And then this is a poll that we'd like to get those of you who are from the public understanding a little bit more about how you're engaging with your leaders at the city and state level and more broadly. So the questions are via how are you how are you communicating and engaging with local leaders via public forums such as town halls, via email, via social media, and all or a combo of the above. Now it looks like we have a good proportion who have voted. The top form of communication, as you can see, is via email. Second is via social media, which I think, yeah, that's interesting to see. Although I guess if you're trying to get in direct contact, unless it's via a messenger app, might not be through social media, and then all or a combo of the above. Dr. Holtzman, do you want to weigh in and just speak a little bit more to what you're finding, where you're finding successes and challenges around this regular risk assessment and hearing communication between leaders and between the public and our public health officials and leaders?
Sure, and Maggie, please jump in if you have others to add. And I know you have some local health officers and others on this call, and they might want to give you a perspective from their aspect. They're being a little bit more closer on the ground, although Montana's small and Helena's small, and believe me, I do hear things when I go out and walk around. But people are communicating, getting information to us in all sorts of ways. I would say that there's aspects that can come to us in a very informative and helpful and insightful way. And then there's others that come to us where I feel people are more just getting across their grievances, which if that's therapeutic to them, that's fine. But it doesn't really help as much as far as trying to think of new venues and how to move forward on some of this. So we really do appreciate the insight where people have concerns, but also talk about solutions or talk about ways that why they feel this is a concern and what things to do about it, or what are some of the priorities we should be looking at. Montana is definitely small enough, and I've learned this from being in similar job in Michigan versus Montana. In Michigan, most things would kind of come through the department and we'd get and talk about it and go from here. Here, people ran high school track with the governor and they call the governor directly, and then I hear it from the governor first. So getting that information across is very important. For me, one of the areas that I use a lot is trying my best to listen to our local health officers and lead locals and those in the community, along with our medical communities, to give us information of what's happening on and try to put some qualitative data and information around the quantitative data that we have. The numbers are very important and they start to tell a story, but as we talked about before, also hearing what's happening on the front lines is really important.
Thank you very much. And this is something that actually after this session, we could send out a questionnaire and get feedback from the participants on this call, a little bit more about where they need support, where they're having challenges, what's working and what's not, because this is such an important part of the ongoing response. So we can send out a few questions and try to get responses as well.
I'll add one other thing that if we send out questions that I'm extremely interested in trying to get more information on, because I know a lot of our local public health folks are struggling and doing an incredible job with the resources that they have. But contact tracing, as we talked about it being a collective response, and people need to follow what the local health is telling them as far as if they should be isolated and quarantined, and really follow that so we can suppress this virus. But it's also really important that our local public health be able to move as quickly as possible, and we'd like them to be able to get contact tracing going within 24 hours and being able to identify these individuals. So it'd be good to get that information back from our folks, as some of them have called and asked for increased assistance and stuff like that, but to continue to be able to work on that, because that's a key component of trying to control this is contact tracing. And like I said, they're doing an incredible job with the resources that they have.
Great, thank you. So we can move on to the next slide. One last thing I just want to say about the regular, the communications and regular risk assessment and engaging community is just continuing to try to find and build allies with local trusted voices like local leaders, religious leaders, teachers, et cetera, getting them timely. I know that we've, my organization and we've spent a lot of time trying to get flyers and resources and posters and information sheets and good, clear communication tools to leaders across at every level of our communities, just to really help ensure that everyone feels empowered to support the process. The next slide is focused on reopening. Jordan, if you want to just quickly touch on this, and then we can continue on with the final tools and open up for Q&A.
Sure. I know we're a little bit short on time, so I won't dig into this as much, just as I covered it a little bit in the data portion. But again, I wanted to emphasize that transitioning between these phases is not unidirectional. You can go back to re-restricting. And then the other thing from a data perspective is that when you're looking at your local COVID case counts, there's always going to be some sort of delay. For example, we're expecting at least 5 days on average between infection and showing symptoms, and then anywhere from a few days to perhaps longer, and in more dire circumstances from getting those test results and having them show up in the dashboards that you all are using every day. So when making reopening decisions, the one thing I would like to emphasize is that you are making decisions with data from at least a week in the past. And so looking at trends in movement in these numbers that we've recommended is just as important as looking at the raw numbers themselves. So you don't want to begin reopening aggressively when you're looking at a trend in test positivity or raw case counts that might continue in that direction before you re-implement control measures. And then I think I'll leave this to the Montana folks to talk a little bit about what's happening locally.
Thank you. Yeah, so we are, and I think we did cover this. We are, we are in phase 2, and we're reopening, somewhat quickly, and have rolled back and instituted the mask mandate. And I don't know if we want to get into that in too much detail now. Maybe we should get through the tools and open up for Q&A, because I do feel like that's going to be a place where questions around all of these topics are going to come up. So unless Greg and Maggie have something specific, why don't we move on to Jessica going through the rest of the tools, and then we can open it up and have that conversation.
Great, thanks, Cora. So I have up on the screen right now, I'll walk through just two resources. So the slide that you were just looking at has a number of resources that we've shared with various Montana groups and outlets, and they're all pulled from our Frontline Guide, so the COVID Local series of resources. Many of them can be found here by going to the site and clicking resources, and you can sort it by topic or phase, things like modeling, what to do with response, what does an urban environment look like as it relates to security, and then what are the broader international resources that are being used. Two of the resources that we specifically call out on the site are COVID Act Now and this the idea around a convergence of metrics, so using that for a risk assessment. And here I'll focus on COVID Act Now. It gives you an overview. It's US based, but then you can drill down into individual states or counties, and there are 5 key indicators that they focus on. So this is all active data that's being gathered. So it's new cases, infection rate, test positivity, ICU headroom, and contacts traced. This is a nice accompaniment to the COVID local site. Our suite of tools focuses on decision-making and policies and questions that need to be asked, whereas the COVID Act Now site and the other Pandemics Explained site gives more active counts of data. And so when we look at Montana, we can drill down into what do those indicators look like on a state level, but then also, say for Missoula, we can go down to the individual county. And it gives just a nice high level overview of where the case counts, the infection rate, all those indicators are for that particular location. In the interest of time, I will pass it back to Jordan. She is going to share with us the analysis and mapping of policies tool that we have on the COVID local site.
Sure, I'll go ahead and share my screen. So at Georgetown University, we have a small army of student researchers who have been tracking specific policies for every state and several different counties throughout the US. So we've developed this COVID analysis and mapping of policies tool, and what it does is it takes all of the policies that we've tracked for different states and localities over the past 6 months and associates those specific actions with changes in COVID-19 transmission. So on the website, we have a few different components. We've got policy maps where you can see different stages of restrictions for different states and even some countries around the globe. We've got a database of policies that you can filter by different, just different categories. So you might want to look at policies in Montana only. You might want to look at policies related to tourism and outdoor activities, and you can filter that here. But what I want to dig into right now is the policy model, which allows you to see how different control measures might impact case counts in the future. So this model helps you visualize when policies were implemented in each state and to predict how future policies might impact caseload. And then another thing we do is provide a what if we didn't do anything counterfactual. So how much impact have the control policies we've implemented probably reduce case counts. That's a perpetual struggle with public health. You never get credit for your successes, but we hope some of these numbers might show the number of cases and cases averted and lives saved by these control measures. So in this choose state section, I am going to scroll down to Montana. You can see the number of cumulative cases to date as of a few days ago. We update this weekly. And then the number of cumulative deaths. And here you can also see over time when different control policies were implemented. So for example, on March 16th, there were initial safer at home policies, followed by a stay at home policy in later March, and then again, moving up to phase 2. So we see up here the percent reduction in day-to-day contacts that people have on average, and then projected case counts over time with existing policies. One interesting thing we can do, so under the current circumstances, our model is projecting that cases in Montana will continue to rise statewide, at least, without any more particular control measures, given the current spike. But one thing you can do here is potentially add a new policy. So for example, a new statewide stay-at-home order or some selective different measures that might add up to something equivalent to a stay-at-home order issued in the major cities. You can select that, apply and run the model, and then see the potential associated reductions in case counts with stricter control measures over time. On the other hand, vice versa, if we instead of implementing more control measures, if we switch immediately to a new normal starting on Monday, what would that look like in terms of case counts? And you can barely even see the existing cases today, because if we reopened everything immediately, cases would rise so dramatically, peaking in the fall with this model. So this model is not perfect. It is a example built up from the real life data that we have given different policies in different states. And one thing we hope to do in the future, especially with the more recent masking orders, is to provide more particular policies that you can model instead of these basic new normal or stay-at-home orders, perhaps seeing the impact of masking mandates and things like that. So I think the best way to engage with the site is to go ahead and play around with it, and I will drop it in the chat if you all want to take a look after this is over.
Thank you so much, Jordan. That's a tool that just launched, I think, 2 weeks ago, and it's a great resource for looking at the impact of existing policies, but also looking at probably crafting new policies as well, right? Looking at maybe, Jordan, if you want to speak a little bit more to how lead public health officials or policymakers might use this tool. Just, I don't know if you have a case example, or, but I think it's something that we obviously are going to see. Public health is a topic now, a big topic now, but we're going to certainly see it as something in the next legislative session. I've been having some pretty big in-depth conversations with public health leaders across Montana about potential attempts to roll back public health authority after, the public didn't really witness or experience the power of public health, or even understand that public health officials have authority. And so this has been a huge education for the public on public health. And so I think that this tool, one of the things I'm excited about with that tool is that it provides a resource for policymakers and public health officials to proactively think through what we might need to do to protect the existing policies we have in place, or to strengthen them, or to adapt them. So yeah, I don't know if you want to, and then we can move into Q&A. But
yeah.
That's my question. I'm going to start with that question.
Sure, yeah. So this tool is so new. It actually launched, I think, just last week.
Okay.
So we don't have any particular case studies yet, but if anybody finds it useful, we would love to hear about it. You could select the contact us email right at the top. One thing that I think might be useful under those circumstances is this element I didn't go over, which is the what if we had done nothing scenario. Using data from states and countries that either delayed implementing control measures or didn't really implement control measures, we can see the number of cases we think might have occurred if none of these stay-at-home, safer-at-home orders have been in place. So I'm going to click view the what-if scenario on the graph, and you can see if we hadn't done anything, if restaurants had stayed open, if concerts had been allowed to occur, all the sorts of things that I know people desperately miss in their lives, myself included, you can see this graph of, we think in Montana in particular, there may have been 60,000 cases a day as soon as late July and today. That obviously would have overwhelmed the health system. And would have caused many more deaths. And so you can see where we think the cumulative cases would be as of today, nearly 500,000 in Montana, and then which I don't know if we're quite where
half
that
our population.
Yeah, half of the population, and then nearly 3,000 deaths. Again, it's not perfect, it's a model, but it's based on real life data that we've been getting from other states and other countries. And I think if you want to compare different states, you could look through different states up here that have perhaps less restrictive policies, and you might see that these numbers aren't totally unrealistic, especially when you look at case counts in Florida and Arizona and Texas and California. Those counterfactual examples might sound extreme, but by comparing and hopefully using that tool, you can get more concrete numbers that bring it home for people who I know miss their day-to-day lives.
That's great.
So we hope that these specifics might help nail down arguments for you all.
Yeah, and build a case, right, for why it matters and why this is. I mean, it's obviously been very painful for everyone. And, you know, to see that and to be able to carry that forward and say, this is why we are all, we're in pain now, but this is the payoff.
Yes, this is the pain that has been avoided. So.
Yeah, the pain that has been avoided, and certainly one of the major parts of the conversation is this balance between public health and the economy. But that's really incredible. So thank you for walking us through that. We only have 12 minutes left. We are looking at doing we also have the option of doing a 4-hour training through this Public Health Training Center, where we go really just specifically through the tools more in depth and maybe get more feedback from some of the participants beforehand on what you want to cover. But this was an introduction, a review to see that these teams of experts, many more people behind the scenes here have been working around the clock to build these tools for public health officials to use around the country and local leaders. So would love to open it up for questions. Emily, I don't know if you want to have people raise their hands, if you want to unmute and have, I see there's a question from Jay Hauer about, is there a surge capacity line that could be put on there? So I think, I'm assuming, Emily, do you want to unmute and see if people want to ask their questions directly?
Yep, people are unmuted, though you can unmute and mute yourself. So however you guys want to do it, they can use the chat box or they can just holler. Note that you all have.
Hello. I have a question. Can you hear me?
Introduce yourself, yep, and just say where you're from.
Oh, okay, yeah. My name is Lisa Biskevich, and I'm from Missoula, and I work at the health department, and I really respect all the hard work that everyone is doing in our community, and Ellen and Cindy and their leadership in Missoula County. And I just have a really direct yet complex question that I'm having a hard time understanding to communicate with the different coalitions and community members that I work with. And that is, if our testing and contact tracing is limited, and we cannot control that at a local level, and it's taking anywhere from 7 days to 10 days to get test results, how are we going to get on top of this pandemic with quarantine and isolation? And my question is going to, with our workplaces reopening, and our schools about to reopen, that there is a lot of fear and mistrust in what's happening. And so what I'm seeing now and getting phone calls with my work in health promotion is that somebody is hearing through their workplace that they have been identified, an employee has been identified to test positive for COVID, but the employer hasn't told the employee this. It goes through the employee grapevine. And then they go to their doctor to get a test because they're scared, or they live with grandma who's taking care of them. And then the doctor says, well, we can't give you a test because you're not symptomatic. So I just want to say that I think human behavior plays a huge role in our response to COVID. And I just have deep concern about how people self-diagnose and process what's happening in our community and by word of mouth. And at the coffee shop, or on the street, or at the park, So I would just say that I see that as we continue to reopen and live in this space of limited capacity around testing and contact tracing, that I just have deep concern for that. So thank you for listening.
Thank
to
you.
that one
And that is,
question.
yeah, no, I think that is, I think that this disease is very scary. There's also a lot of stigma, and that's one of the challenges we're seeing in Native communities, but even actually across the country, across the state. People are ashamed if they get it. They don't want to share it. They're also really afraid. And so there is a huge amount, just the unknown, hearing stories of 30-year-olds die who are otherwise healthy dying. And I mean, there's not misinformation. It's just that we're all learning as we're going. And so I think that that's the lived, that what Lisa just went through is really basically the lived experience for everyday people. So great. Yeah. Dr. Holton, maybe I'll pass it over to you.
Yeah. And I just wanted to add on to what Lisa's saying. And also, this is where okay, I'm on mute. So
Yeah, we hear you.
this is one of our biggest challenge, Lisa, as far as our communication, and it's very hard because there's so much cross communication going on, and the public health information is not always getting out there. And one of the challenges, so as public health, and we've often worked with under resources for a long time, but I just keep moving forward with whatever we got, and we got to keep figuring out how to move things under the situations we have, and continue to try to work to improve those as far as the testing is concerned. But a couple points. One, we need to keep educating people over and over again that if they're really a close contact, they need to be in quarantine. And they shouldn't be affecting others in that way. So some of the folks that are coming into different doctors' offices, and this is a communication we need to get to doctors, is saying if you are a close contact, you should be in quarantine, and we'll do the test. It might take a little longer to get it back, but the test does not release you from quarantine. It helps us in public health try to get ahead of the outbreak, because if that person comes back positive, you'll make the next circle and move forward. But it doesn't change the individual's response to what they should be doing. And the same thing on the clinical side if they start to have symptoms or anything of that sort. So that message needs to keep getting across. And I think sometimes within the businesses, misinformation is getting out almost as if you get a negative test, oh, I'm free, I can go back to work, or whatever that case might be. And that needs to continue to be reinforced. And I know you know this, Lisa, it's just that I don't think we as a whole across the country have been doing a great job, and probably because of a lot of other mixed messages that are getting out there, to talk about the importance of this with the contact tracing. It's also really important, and we talked again about a collective response. It's also a collective response on how providers and everybody puts their data forward. So we are prioritizing things at the state, and at the state, if somebody's symptomatic or test, we want to get those run through quickly, as are the contact ones. So anybody that's a close contact, that's another person we want to move quickly, because that is so important to public health, again, to try to get ahead of the outbreak. And so having those priorities and knowing that is very helpful. When some people put priority on everything, obviously we don't know the individual patients, it clogs things up, and it doesn't allow us to get, with the limited resources we have, the ones we need to get through first. And ideally, I would love to have more testing, and I think there's all sorts of places we can continue to discuss that. And I think there should be some incredible investigations on all of this when we're all done with the outbreak, but we've got to continue to move forward with what we got right now.
Yeah,
but thank you for doing it. I definitely hear you.
Yeah, thank you, Dr. Holtz. And one of the things that we heard on one of another recent forum on this was the advice that between testing and when you receive your test results, you should quarantine. So you shouldn't test and then go about your life and until you get your results. Once you get the test, you should try to limit your movement until you get the test results. Is that right?
That would be true for anybody that is known close contact, or of course somebody that has any symptoms.
Right.
If they're in the surveillance aspect, then that might be a little different, although our surveillance testing has decreased considerably right now due to limitations of testing. Still doing a lot with nursing homes and high risk populations. So
thank you.
This is Jordan. I think we had received also a question on surge capacity for ICUs and hospitals, and whether you can see that within AMP. I am going to share my screen and show you a little bit of what that looks like on our tool. So right now we don't have a line on the graph where you can see the limits of ICU surge capacity by state. If that would be useful to people, I think that's something I can propose to add. But one thing you can do is go up to the top, and instead of showing COVID count by the number of cases, you can look at the number of people hospitalized, and then that will change the graph below to see instead of the raw number of cases, how many people we're projecting to be hospitalized on any given day going forward in the future. So in addition to just pure hospitalizations, you can also see projected number of people who will be in ICUs. And I think this is where that surge capacity line might come in handy, where we might add a line for ICU capacity and then surge capacity by state. So again, these are just projections going forward. We do not currently include limits on ICU capacity by state, but that's a great recommendation. So thank you for that.
Thank you, Jordan. I know we only have we have 1 more minute, so I want to thank everyone for joining us. I know everyone's got a very full schedule. Dr. Holzman and Dr. Cook, if you want to stay on a little bit more to answer some questions, I think that we can continue to use this platform and meeting. But thank you to all of our speakers today, to the Montana Public Health Training Center, to all of the participants that came for your hard work. I didn't recognize at the top, and I really should have, how grateful that we all are for the hard work that you're doing across the state to keep our communities safe. You're dealing with a huge amount of ambiguity, fear, challenges on every front. This is definitely a marathon, and we are so grateful to you for the work that you're doing. We want to be a resource. We'd love to collect more questions from you. Via email, we can send out an email to follow up on this and just, maybe send out a little survey or see if we can collect more questions from you. What we'd love to know is, are these tools useful? What else might you need? We've been trying to share public health information, flyers and just community education materials through various platforms to help you stay up to date and have, like, as Lisa brought up, really very clear talking points on what to tell the communities that you're serving. But we are in this together, and we are here to help support you in whatever ways you need with these resources, and just continuing to convene smaller group meetings if you need to talk through some of the challenges that we're continuing to face. So I don't know if anyone else has any final words, but thank you very much for joining us today. We will be looking into hosting a longer, more in-depth seminar to get into these tools and more interactive, where we have breakout sessions, et cetera. This was really more of us talking at you, but we wanted to get this presented to you in a fairly succinct way, so that we can continue to work together over the coming year and more. So thank you all for coming. I don't know, Emily, Greg, Maggie, Jessica, any of our presenters want to say anything else?
Cora, I'll say one other last thing, and then I'm happy to answer further questions or do this at a later date. But one question I saw in your chat early on, and it's brought up all the time, is death certificates, and are we overcounting basically COVID-19 or undercounting it? Most likely undercounting it, but a death certificate, just so people understand, and this is how it's been done forever, for a long time, is somebody might die from a blood clot, a pulmonary embolism. It will say pulmonary embolism. Then it will say caused by, and there's a lot of things underneath it. So they might have had a thrombus or a clot in their left thigh, and that might have been, they might have also had acute liver failure, and then they might have had cancer, moderately differentiated hepatocellular carcinoma or something like that, meaning that all of these contribute to the ultimate death of that individual. So somebody who dies of respiratory failure and has, had COVID-19, you would see how that might fall into the categories or some of the other aspects. There's also a line on significant contributing to other factors to death. A good example of this might be somebody who dies from a heart attack. It would say underneath they had, atherosclerotic heart disease, but they might have a significant condition contributing to that death and might say, tobacco use or something of that sort. But so that's how that information is collected. And that allows us to get an idea. Are there numbers that are put in there? Definitely. probably in both directions. There's some miscalculations, but overall, kind of going back to the idea of epidemiology cutting with a butter knife, this really gives us a very good trend and an understanding. And I don't think somebody should get as caught on, you know, is there 140,000 and 333 people, is that all exactly right? There's probably more, but you kind of look at that and how that rate is rising to really get an understanding of what's happening in our community, and that we need to move quicker, faster, and more coordinated. And I think those outcomes are pretty clear. Thanks. Sorry, for letting me ramble.
No, that's great. And that is a big question right now. I'm seeing that pop up all over. So that was and I'm glad you remembered to answer it. Any other last questions? I know a few of our presenters have to go move on to their next meetings, but
I would just like to add from the COVID local team, thank you so much for this opportunity to speak with you and to highlight our experts, Jordan, Haley, Beth, from the COVID local team. These interactions are always so helpful to us, and the questions that you ask, so that we can refine our tool to make it more accessible, more useful, more practical for local leaders. That's what we set out in mid-March to accomplish, and our suite of tools have grown, they've matured, and it's been because of this feedback. So we're always open to hear more, and you can get us directly through the emails that are provided or through our website at covidlocal.org. If you hit contact us, it comes to me, so a real person, and I'm happy to field any questions that you might have. So thanks for your time.
thank you all very much. Have a good, safe day, and we will work together with you to design the next session so that we can go even more in depth into the things that you care about. Thank you all for your continued service.